Antibiotic resistance is a growing concern that threatens the effective treatment of infectious diseases. The World Health Organization sounded the alarm in their report published back in 2014, issuing a call to action for all government sectors and medical organizations, as well as society overall, to engage in efforts to mitigate antimicrobial resistance. Earlier warnings about antibiotic use in the United States were brought forth almost a decade earlier by the Centers for Disease Control and Food and Drug Administration, which led to the formation of the Scientific Panel on Antibiotic Use in Dermatology, referred to as SPOUD. Dermatologists have only recently received attention regarding potential contribution to antibiotic resistance, largely based on the fact that, per clinician, we prescribe antibiotics more often than any other specialty. At least 20% of all prescriptions written by dermatologists are for antibiotics, accounting for 11.5 million oral prescriptions and 6.9 million topical prescriptions annually. 2/3 of these antibiotic prescriptions are for acne, which merits special attention as it is a chronic disorder requiring prolonged courses of treatment as compared to a week or two duration to treat a common infection. It is important to discuss these questions from two different angles. First, there is the concern that if a specific bacterium develops resistance to a commonly used antibiotic, that antibiotic will no longer be effective in treating conditions caused by that bacterium, whether it be an infection or an inflammatory disorder such as acne. However, what is also a concern from a public health standpoint is the emergence of resistant strains in commensal or off-target bacteria that are coincidentally exposed to an antibiotic during treatment. This is what my colleague Dr. Jim Layden has termed ecologic mischief. Bacteria that are present as innocent bystanders are still exposed to the antibiotic, with the potential for their own selection pressure and emergence of resistant bacterial strains. Antibiotics have been a mainstay of acne treatment for years and will probably remain so for some time. However, modifications can be made that support their use more responsibly. The American Academy of Dermatology guidelines, amongst others from SPOUD and other groups, include the use of topical or oral antibiotics as a vital component of the initial treatment for acne, selected based on severity and used in combination with other agents to optimize therapeutic effect and mitigate bacterial resistance. The key is responsible use and determining an exit plan over time that achieves success for each given patient, especially with oral therapy. Right now, we use both oral and topical options for acne. When it comes to oral antibiotics, tetracyclines are the predominant agents used first in most patients with moderate to severe acne comprised of many inflammatory lesions, when response to a topical regimen has not been satisfactory. Of course, the clinicians must evaluate prior use and medical history to avoid potential adverse effects or contraindications with the tetracycline agent selected. Antibiotics are not recommended as monotherapy for acne and are best used in combination with a topical regimen that includes benzoyl peroxide and a retinoid. Currently, the topical antibiotics that are most often used to treat acne are available as standalone products or as topical combination products, usually coupled with benzoyl peroxide. We recommend that these antibiotics be used in combination with benzoyl peroxide, which augments efficacy and decreases the emergence and development of resistant bacterial strains at sites of concurrent application. Since the time when these antibiotics first became available for topical use, we've seen that the prevalence of resistant strains of Cutibacterium acnes, formerly referred to as Propionibacterium acnes, has increased progressively over time. These resistant strains can now be found in more than 50% of patients, depending on the antibiotic, with higher rates noted especially with erythromycin, followed by clindamycin. Evidence does support that C. acnes resistance can correlate directly with a greater chance of treatment failure. As a result, the use of topical erythromycin has diminished markedly, as C. acnes resistance to erythromycin is widespread globally. Additionally, topical erythromycin has been associated with an increased prevalence of erythromycin-resistant staphylococci on skin and in interior nares, many of which are also cross-resistant to clindamycin. This is the type of ecologic mischief we hope to avoid. It is the development of this collateral bacterial resistance that warrants vigilant methods to assess the future threat of emergent multi-drug resistant bacterial mutants. This is vital, as these mutant bacteria have the capacity to incorporate and pass on to other bacteria packages that include genetic means for resistance to multiple antibiotics.